Hi, everyone. Let's talk pediatric nurse anesthesia. My name's Anna. I am a third year nurse anesthesia resident, and today is the first episode of season 2 of the Compton Care Academy podcast. For those of you who are joining us for the first time, Compton Care Academy is a community of ICU nurses, nurse anesthesia residents, and CRNAs who love critical care and love ongoing education. Hand it over to Chrissy to talk a little bit more about it.
Yeah, if you haven't met me before, my name's Chrissy. I've been a nurse anesthetist for 7.5 years now. I co-founded Confident Care Academy with Anna to help people who are aspiring CRNAs grow in their journey. Today, we have Kate with us. She's our newest team member at Confident Care Academy. So we're really excited to have her on to introduce her to you guys and to talk about her specialty, pediatric nurse anesthesia. Kate is a pediatric CRNA, educator, and mentor. She loves being part of the Confident Care Academy team. We're so glad to have her. Right now, she's also working on establishing a COA accredited, that's the Council on Accreditation, pediatric CRNA fellowship at her hospital. So we're really excited to dig into what that looks like.
Hi, Chrissy. Hi, Anna. I'm so excited to be here today.
So, Kate, if I remember correctly, you told me that you used to be an adult ICU nurse before you were a pediatric ICU nurse. And this is kind of what jump-started your interest in pediatric anesthesia. What made you want to make that initial transition from the adult world to the pediatric world in the first place?
Okay, so there's a lot of lore here. I knew that I wanted to be a nurse anesthetist from the time that I was a senior in high school. So that was the goal. And it was like, have to get into the ICU right away so that I can do this as quickly as possible. And when I was in undergraduate nursing school, I had a couple of professors tell me, like, you need to go into pediatrics. Like, you are that girl. You have that personality. You have that ineffable quality that can't be taught, where, like, you know how to connect with kids. And I've always been that way. Like, I'm an oldest sister. I love my younger sister. I have younger cousins. I had younger neighbors. My sister and I, like, if we go on vacation somewhere, by the end of like travel, there's like some 4-year-old girl who's like, will you come home with me and be my best friend forever? Because like we just connect with kids easily. Our mom is that way too. So it was always in the back of my mind that I was like, oh, maybe pediatrics is the right path for me. And I kind of had it in the back of my mind as like, maybe if anesthesia doesn't work out, pediatrics will be the path that I go down. So I ended up getting into the adult ICU right after graduation, and it was like a big, bad adult ICU. I applied to anesthesia school, one program, after 1 year of experience, and I got an interview, but I did not get in. If I did, I would have been in your class, Chrissy, but
Oh my gosh, that's so funny.
not the way, not the path that I was meant to go down. So I was really, really dejected when I had that first rejection to anesthesia school. And I had been in the ICU at about like 2 years at this point. So I thought, okay, maybe this is time to try pediatrics and see if pediatrics truly is the thing for me. And I decided to go to CHOPS Cardiac ICU. And I was like, let me give this a try, see if it's it, see if like I still have the itch to go to anesthesia school, or if just being in the pediatric ICU is going to be enough. And
About CHOP, about
what's
that
that?
hospital for those who are not familiar with CHOP. Can you talk a little bit about that hospital and like that specialty? Because for those on the East Coast, you've probably heard of CHOP. If you're not on the East Coast, you might not have. So what was that hospital like a little bit?
Absolutely. So CHOP is the Children's Hospital of Philadelphia. It's one of the top ranked pediatric hospitals in the country. People come from all over the world to go there. And they have a very large, very busy cardiac ICU. They really specialize in like the hypoplastic left heart population. And it is a big, bad, busy ICU with very tiny patients. So I went there, and just a complete learning curve and change going from the adult ICU to the pediatric ICU. Like the first time they were like, oh, we're going to have you hang potassium on a patient. I'm like, great. Okay, I'll get a bag. And they're like, no, you're going to give 6. And I'm like, 6 what? Like, they're like 6 MEQs. I'm like, oh, okay. So small, very demure, very mindful, everything about pediatrics. So I went there and I quickly realized that I loved pediatrics, but I still really wanted to go to anesthesia school. And I ended up getting accepted to anesthesia school. I spent 2 more years in the pediatric ICU at CHOP. I learned so much. I think that the 2 experiences of the autonomy, the big picture of the big adult ICU that I was in, and then the meticulousness and the precision of the pediatric cardiac ICU really put me in an amazing position once I got to anesthesia school to be the strongest student that I could possibly be.
I'm really glad that you told that story because I think a lot of nurses have this really big misconception that they have to be in an adult ICU. It has to be cardiac surgery. They really think it's just one type of ICU nurse who can go into CRNA school. And a lot of people think that pediatrics, for some reason, is not desirable, which I completely disagree with. I feel like program directors really value diversity and experience. And I think a lot of program directors really love pediatric ICU nurses, especially nurses who come from major centers like CHOP or Boston Children's or Children's Hospital of LA. Like any of those big ones are amazing for CRNA school. So my question to you is, a lot of pediatric ICU nurses who go to CRNA school, I've personally noticed they end up going into adult anesthesia. They don't all stay with pediatrics, and vice versa. A lot of people who've always been in adult world end up in pediatric anesthesia because pediatric anesthesia is really different than being a pediatric ICU nurse. It's really not similar in my mind at all. What drew you to pediatric anesthesia? What do you like about it compared to the adult world? Why did you decide to stick with it?
Yeah. So once I got into anesthesia school, I started my first rotation. I was back at like a big bad adult hospital where we had a ton of autonomy as students. And I was like, okay, adults under general anesthesia are not that bad. I could easily go back to adults. Like as soon as I got into the OR and started doing anesthesia, I was like, this is it. I love this. Like, I don't care what patient population I'm working with. I just love being in the OR. And then after, I think it was the first 7 months of my program, I went to my pediatric rotation and I got there in the first few weeks. I was really excited, but I got there and I was just like, I kind of don't like this because I was taking call at my primary site. I was a warm body and they were leaving me alone to do my thing. And then I got to pediatrics and it was like, you're holding the mask wrong. You're taping the tube wrong. You're putting too much pressure on the teeth. And I was like, why are these people hovering over me and telling me how to do anesthesia? This amazing junior student who knows everything. And I was real humbled real quick. And then after about the first month, I was like, oh, I actually didn't know as much as I thought I did. And I actually wasn't as skilled as I thought I was. And there's so much that I can learn here. And it's meticulous and it's precise and people really care. And the surgeons are really nice. And everybody just puts so much of themselves into what they're doing here. And I was like, this is it. Like I was hooked. And I was like, I don't know that I can go back and do adults because like being around the pediatric population just made my heart sing and it made me feel satisfied. And it's interesting that you brought up that point that like people have PICU experience. They go to anesthesia school. They end up going to work with adults. In my class, there were 24 of us. 5 of us had pediatric experience. I was the only one with the hybrid adult and pediatric. The other 4 who were just peds, they all went to adults. I was the only person in my program who ended up going into pediatrics. And I think part of that is people get a little discouraged because like you make less money in pediatrics. You are almost always going to work in the anesthesia care team model. So you're going to work closely with physician anesthesiologists. But to me, like, I don't mind working in the anesthesia care team model. In fact, I really like it. I really respect my physician colleagues. I love learning from them. I love working closely with them. And I love knowing that they are as dedicated and committed to caring for the patient as I am. And then if I need help, they will be there in the blink of an eye. I don't mind that I make less money because typically the 2 pediatric hospitals I've worked in, we have the most amazing anesthesia techs that like you could ever hope for. They do my machine check in the morning. They turn the machine over between cases. They refill the SIVO. They set up our fluids. They make sure the room is stocked. And I'm like, okay, part of my salary is going to an amazing support staff that makes my job easier and less stressful. I don't have to play like treasure hunt or scavenger hunt in the morning, like trying to find equipment or a pulse ox cable that works. Like it's just all there and ready to go. And if I need help, they're there in a heartbeat. I was just telling this story the other day. A few months ago, I was holding the code phone and it went off and I had to respond to a code in the hallway. It was an open belly, compressions, kid accidentally got extubated. And one of the anesthesia techs happened to be standing next to you when I got the call, and he was like, "Hey, do you want me to run downstairs with you?" And I was like, "Yeah, absolutely." Because you know how it is when you get to one of those crazy code situations, you don't know anybody's name, you ask for something, and it's like, it just falls on deaf ears. So he came down with me and he's like, "What do you need?" And I was like, "I need this tube, I need this blade." And he got it, and I got the intubation, and I was just like, you didn't have to do this, but like you made a difference in this child's care today by just showing up and being part of the team and helping me do the thing that I needed to do. And I just feel really lucky to work in an environment like that.
You made two really great points that I think it's hard for people who haven't been in anesthesia land yet to really imagine or fully grasp or understand. A really big part of our job does involve a lot of tasks other than just giving the anesthetic, right? Room setup, room turnover, like what do those things really mean? We are responsible for patient safety from A to Z, and your equipment, your medications, all of these things. When you have resources available to help you in your job, it does make your job less stressful. It makes it a safer practice environment to work in because you have these things already ready to go and you're just double checking. So there's fewer opportunities for error because there's more eyes on it. And it does make the day overall less stressful. The second thing that I really want to emphasize to people who are not familiar is kind of the culture of that work environment that you're sort of alluding to. I've also noticed that in pediatric hospitals specifically, now pediatric anesthesia isn't always exclusive to pediatric hospitals, right? At my hospital where I work, I take care of children as well. Like peds are mixed into the adult population, but I'm talking specifically major, children's hospitals, if that's something someone's interested in. I love that you brought up like everyone's kind of like nicer, everyone's really meticulous. That culture of safety really takes priority. The patients come before profits, and that's a theme that I've seen at many children's centers. And the only place in the adult world that I've really seen it taken to that same level of seriousness is in like cancer hospitals. That's the other place where people tend to all be there because they really care about the patients. It's like very personal to them. And you find the culture, it's way more patient centered and family centered. And that is a really special environment. Anna, have you seen that at all in your training so far or in your nursing years? I know you've gone to a lot of different facilities at this point.
I want to just echo what both of y'all are saying here. It's been really interesting to rotate between some larger academic centers and then more rural rotations as well. And pediatrics are everywhere. I often will be at the more rural centers or larger academic hospitals that have healthy pediatrics. It's not like the HLHS. It's not like the very specialized congenital kiddos. But I will also just add that I think as ICU nurses, we're often in such a race to kind of get to the finish line, if you will, of like anesthesia school. Well, you get into the ICU. It needs to be an adult ICU and it needs to be a cardiac ICU, which we, debunked a few times. You can work in lots of different critical care environments. So you're in a rush to kind of get your ICU experience. You're in a rush to get into CRNA school. And then something that Kate, you brought up was talking about how you like the longevity of your career and you like your work environment. Once you're a CRNA, you're not trying to get your 2 to 3 years of ICU experience and then your 3 years of CRNA school. You have 40 years or 40, 50, 30 to 50 years of working in an environment. And it makes a big difference to have a team that you like working with and the support staff who like what they do and to have those resources. And sometimes you mentioned, you might make a little bit less money in pediatrics. You might make a little bit more money in some of these rural rotations that I've been to. I also have found out that I often in those rural areas will not sit down because it's all about production pressure and room turnover and sprinting in between to the point where you're not really getting breakfast breaks. So then you feel at the end of the day where you want to like prop your feet up on the wall because you've been running, you did 17,000 steps in a day. That leads to burnout, So that being said, Kate, do you feel that you experience burnout because you care so much? Like what are your favorite cases that you've seen? Are there any cases that you try to kind of avoid? Do you feel that you like experience burnout, or what are some of your favorite cases working in pediatrics?
Yeah, so I think burnout can happen in any profession, in any specialty. I remember when I was on rotation at a different pediatric hospital as a student, I was working with an anesthesiologist who said to me, like, I think I'm going to go back to adults because I miss being the person who cares the most. Like, he's like, I have care fatigue working with all these other people in pediatrics. I personally don't feel that way, but I can understand like how people make pediatrics seem like it's like not as hard or like, it's easier because it's peds. And I'm like, it absolutely isn't. Like the stress and the responsibility of someone handing their baby over to you is like the tension in my shoulders is like up to here every day because I'm like, this is so precious and this is such an honor that I get to do this. So I could see where that could burn someone out. After the pandemic, I definitely felt myself feeling like a little bit more burnout, a little bit more tired. And I actually scaled back my hours to be part-time. So I'm in the OR like 20 to 30 hours a week now. And I spend the rest of my time doing stuff with you guys for Confident Care. And this is like the perfect balance for me. Because when you're only in the OR like 2 days a week, it doesn't matter if it's like getting to be the end of the shift and it's like, oh, the patient's going to pick you. I'm like, whatever, I'll just stay and finish the case because it's the right thing to do by this patient. And it's a lot easier to do that when you're only there like 2 or 3 days a week than if you're there 4 or 5 days a week. And that being said, favorite cases. So I love orthopedic surgery. And I'm really lucky I'm at Nemours now because it's a huge orthopedic hospital. Like Nemours isn't quite as big as like CHOP or Boston Children's or Children's LA, but it's still a dedicated pediatric facility. And we deal with the skeletal dysplasia population. So kids come from all over the country to get their specialized care here. So we do a lot of orthopedics. We do complex ortho. We do healthy ortho. And I just love being in an ortho room, sports med especially. Like you give me 3 like healthy teenagers with ACL repairs, and I am like in my glory. When I worked at Boston Children's, I also really loved being in the cath lab, and I didn't want to go there. I didn't think I was going to like it. And then once I got up there, I was like, I actually like really love this. I loved the people that I worked with there. Like it was just the best group, like the cardiac anesthesia group there. And then all the cardiac cath lab nurses, the cardiologists, the techs, like everybody there was so amazing. And peds cardiac seems really complex, and it is, but it's also like there's only so many defects and there's only so many places that the blood can be shunting. So once you understand that, it's a lot more manageable. And I really enjoyed my time there. It made any crisis anywhere else seem so much smaller. Like after you've like crashed onto ECMO with a kid, it's like pushing a little bit of epi at the surgery center doesn't seem quite as scary after that. So I think it made me a stronger provider. And then my least favorite cases have to be NICU neonates. They scare me to death. And ironically, like when I was up in Boston, I used to give a lecture on the nuances of neonatal anesthesia to the students who rotated with us. And I gave like a presentation at our CRNA rounds about it. And I still refer to this lecture that I created anytime I take care of a neonate because I'm like, these are really helpful tips. And I feel taking care of a neonate is like running. Like I love to hate to run. And the whole time I'm running, I'm like, I hate this, I hate this, I hate this. And then I finish running 3 miles and I'm like, oh my God, I feel so good. And I'm so proud of myself. And I feel like taking care of a neonate is the same way. Like I'm walking to the NICU, my hands are shaking. I'm moving this tiny, like 1,000-gram baby over to the OR table. And I'm like, oh God, oh God, oh God, oh God. And the whole time I'm like so tense. And then at the end, I get them back to the NICU and I'm like, I am insane about making sure they stay as warm as possible because that's what the NICU cares about the most is that they're over 36.5 Celsius when we get them there. So I have my little like thermocap on them and the warmer and all the things. And I get them there and they're safe and they take the temperature and they're warm. And I'm just like, I am so slick. I took such good care of this baby, even though like my heart rate was probably 140 the whole time I was doing it. Afterwards, I'm like, I did such a good job.
I think as a trainee, it's really relieving in some ways to hear that people who have been CRNAs for a long time still like get nervous.
Oh, absolutely.
It's helpful, I feel, as a trainee to hear that people who have been experienced for a really long time like you still care. You care that much that you feel like your full body is engaged with like the care that you're providing. You also talked a little
Absolutely.
bit about lectures that you give a couple of different places. And you mentioned earlier, you're talking about a pediatric fellowship. What
Yes.
are those for people who are in training or are interested in becoming CRNAs? Like, what's the process look like to create a fellowship program? I'd love to hear a little bit more about that.
Oh my God. So this has been my passion project for like the last 18 months. Now that it's wrapped up and I'm awaiting to hear my answer, I find out on November 19th. So hopefully by the time this podcast comes out, we can put in the show notes that like, yes, it was approved. Hopefully I'm waiting to hear. And then once it's approved, I can spend more time working on confident care stuff. So the Council of Accreditation is the accrediting body for nurse anesthesia programs. Every nurse anesthesia program that's accredited has to go through the Council of Accreditation. They very bureaucratic, making sure that they're like checking all the boxes, they're doing all the things. And recently they've been starting to roll out some of these accredited nurse anesthesia fellowships. So currently, I believe there's 5 or 6 regional pain ones, and then there's 3 pediatric ones. And we had one at Boston Children's Hospital when I was up there, and it was just such a phenomenal complement to your anesthesia school training to help you come into the world of pediatric anesthesia and become a more specialized provider. So when I left Boston Children's and I came to Nemours, this was something that was kind of floating out there as an idea in the department of, oh, maybe we'll try to do one of these. And I was like, I'm your girl. Like, I just came from a hospital that has this, and it was accredited. It worked great. Obviously, each hospital is going to need a little bit of tailoring to make it specific to that hospital, the patient populations they're seeing, the type of cases and those things. So I'd say probably about 18 months ago, I started working on this. And what you'll do is you'll reach out to the Council of Accreditation. You'll let them know that you're interested. You have to like sign all these forms and submit an application fee. And then they send you this self-study, and it works out to be like 20 plus pages when you're all done. It's all these questions, and it's all these very detailed questions about like, what is your plan for this? What is your vision for this? How are you going to do this? How are you going to ensure this? How many cases do you have each year? They currently don't have any guidelines where it's like, oh, it has to be 400 cases, or it has to be 200 ENT cases, or 15 art lines, or whatever. It's just like, you come up with what you want to come up with for your hospital. So what I was able to go in and do was, we use the Epic charting system. So I was able to go in and look at new hires over the last few years and the case numbers that they were getting on average for neonates, for the different ASA classes, the types of cases, things like that. And then I looked at the ACJME guidelines for physician pediatric anesthesia fellowships and the case numbers that they required. And I was able to kind of create like a hybrid with those guidelines of what would be feasible at our hospital and what I think would be beneficial to a new graduate or someone who's coming in with adult experience but no significant pediatric experience, to help go from either, a proficient anesthesia provider or a novice new grad into a competent and proficient pediatric nurse anesthetist. So it's a 12-month program. The first 6 months are the most intense of it, and we have them rotating through this different surgical subspecialties. So like the first month, the plan is to just be an ENT and endo. When you're in ENT and endo at our hospital, you're typically working one-to-one with an attending anesthesiologist. So you have them there kind of more involved, more support, like they can kind of oversee you a little bit more, give you more tips and tricks. It also gives you the benefit of really getting to master your airway skills, masking, intubations of kids of all sizes. When you're in ENT, you're getting those numbers very rapidly. After that, because we're a big orthopedic center, you would move on and be in healthy ortho, which is kind of a nice transition if you're coming from adults or you're coming from school, because a lot of the ortho cases tend to be healthy or older kids. It's not little babies necessarily. After that, you move into neurosurgery and complex ortho. So you'll be doing neuromuscular spines there, working with the skeletal dysplasia population, kids who have really challenging airways like Morquio syndrome, things like that. And then after that would be like GI and urology and so on and so forth as you rotate through all of these subspecialties. In addition to that, I've created a didactic curriculum that complements the clinical subspecialty that you're on. So I went through, we have like an online library that all employees of Nemours have access to. We have online textbooks, journals, articles, PowerPoints, presentations that have been given by members of our staff, CRNAs and anesthesiologists in the past at either like resident and fellow lecture series or conferences, things like that. So I've compiled them into a place where it's like, okay, you're doing neuromuscular spines this month. Here's all the information you need didactically to complement what you're seeing in the clinical setting, just to help advance your own knowledge. Because I think a lot of people, unfortunately, they graduate anesthesia school and they're like, I don't want to read a textbook ever again. I took the board, I passed the test, like I am done. And you can't be that in pediatrics. I've been a pediatric CRNA for just about 6 years. And I look at my patients the night before I'm in clinical every single time. And if they have a condition or some congenital disorder that I'm not super familiar with or that I haven't dealt with recently, you better believe that I'm reading about it. I'm looking up anesthesia implications for it. I'm not writing out like a 20-page care plan like I did when I was a student, but I am going in prepared the next day to take care of that child in the best way possible because they deserve it. So I want to have those resources readily available to our fellows. So they're not just going like, I don't know what Morquio is and I don't know where to find information about it. And I'm like, oh, great. Well, we have Mary Thoreau and Abe Oven, who are fantastic anesthesiologists who've written a bunch of articles on this because they deal with this very specialized population. And I happen to have the articles right here ready to go for you so that you're going to take the best possible care of this patient tomorrow. And then the third aspect of it is mentorship. And I think mentorship is so important. So every fellow who comes in will be assigned a mentor who's been at Nemours for at least 2 years as a dedicated pediatric CRNA. And they're just there to kind of be your go-to person with any questions, problems, troubleshooting, navigating that you're going through. And I had this when I was up in Boston and I went up there. I didn't know anybody as a new grad. Like I didn't know anybody at the hospital. And it just really meant a lot to me that I had my Kate Potter. She was my mentor. Just to have her as my go-to person. If I had questions, I needed to help like navigate. I had never been in this kind of case before. I was having trouble with certain personality or whatever. And like, it made such a difference to me to have that level of support. And I'm so excited to be able to give this to people who are coming into our hospital. And my goal is that after that first 6 months, I want the fellows to be able to walk into any room, any case, and feel confident in their skills and their knowledge to take care of that patient. And where they feel they have any gaps, they're going to know who their resources are to go to for help.
I love that. This is such a well-designed, well thought out, comprehensive program. And, you mentioned earlier, like there's only a few pediatric fellowships in the country. And I think there's a lot of misunderstanding and misconception about what a fellowship is. So I just want to clarify that a little bit because it's a little bit different than what nurses are used to, right? We're familiar with the concept of fellowships for surgeons, right? Like most ICU nurses hear about physician fellowships and how, it's required to have a fellowship in plastic surgery and then pass the plastic surgery boards to call yourself a plastic surgeon, right? In anesthesia, things work a little differently. So, for example, and I'm going to just speak about just physicians first. So if you're a physician anesthesiologist and you go to and finish your 4 years of anesthesia residency, you can do obstetric anesthesia even without an OB fellowship. You can take care of pediatric patients even without a pediatric fellowship, right? People do this all the time. But if you want to be in a center that specializes in high risk OB, there are physicians who exist in those centers who've kind of been like grandfathered in over the years. They have tons of experience, but newer, younger anesthesiologists are now kind of expected to go into an OB fellowship before they take a job at like a center where they'll do high risk OB, or if they're going to work at a Children's Hospital of Philadelphia or a Boston Children's or some sort of a major pediatric center, they'll typically be have a pediatric fellowship. Or even if they're in charge of pediatric patients in a mixed hospital, like where I work, all of our pediatric anesthesiologists have had pediatric fellowships. But in the CRNA world, fellowships are newer. We do get exposure to pediatric anesthesia in CRNA school. I've never done a pediatrics fellowship. I do take care of pediatric patients, but I am not highly specialized. So I don't take care of our NICU patients, for example. We do have a specific pediatric anesthesia team of CRNAs and anesthesiologists in my hospital, and the pediatric CRNAs who are more familiar with it do the NICU cases, for example. So you can get trained on the job in your hospital. That's how it's been historically. You don't have to go to a pediatric fellowship in order to take care of pediatric patients. However, this is becoming a growing trend because this is a better way to equip people for those highly specialized pediatric patients, like the more acute patients, like the NICU babies, like congenital pediatric heart disease, right? There are CRNAs. I'd like to debunk this too while I'm on my soapbox. CRNAs do, in fact, do cardiac anesthesia. Every children's hospital that I know of has CRNAs in those rooms. So if you're wondering, there's your answer. So fellowship programs or mentorship programs, or even if they don't have an official fellowship, there's typically a very prolonged orientation period and a lot of training that goes into it. But I think fellowships are the future. They're growing in popularity. A lot of specialties are talking about creating fellowships from scratch. There's talk of creating OB fellowships, cardiac fellowships for CRNA. So this is definitely the move of the future, a trend that we're going to be seeing more of. And I think it's a good thing.
When I started at Boston Children's, it wasn't an approved COA fellowship yet, but they still did all of the things with me. So even though I don't have like a certificate that says like, yes, I completed this, like I did all the same things that the people who started after me once they had official accreditation did. And it's just so helpful. And a couple of the other things that I feel like come up as like rumors or like conjecture or like worries about pediatric fellowships, you're going to get pushback from physician anesthesiologists for using the word fellowship, and they don't own the word fellowship. There's lots of specialties that have nothing to do with healthcare that use the word fellowship that just means more specialized training. We're not trying to take away physician anesthesiologist fellowships. We are just trying to educate, mentor, and help nurse anesthetists specialize even further with these very specialized populations like pediatrics or high-risk OB. At my hospital, at Boston Children's Hospital, if you come and you join the Pediatric Nurse Anesthesia Fellowship, you are getting paid the same as you would if you were staff there. Like, it's not like we're going to pay you $50,000 a year because you're in training. Like, you're getting your full CRNA salary, you're getting your full CRNA benefits, healthcare, maternity leave, all of those things. You're able to take vacation time, you're able to take conference time, and there's also no obligation to stay at the end of the year. So if someone was interested in coming to Nemours or Boston Children's and they knew they were only going to be in that area for 1 year and they were going to move to LA after that and go to Children's Hospital of LA, but they wanted a specialized pediatric anesthesia fellowship experience, they could come there and they could do that with us for a year. And you wouldn't end up on like a no hire list or like you came and you left. It's like, no, this is part of it. Obviously, we would love to keep the people that we train in these fellowships. But even if it was someone, I was talking to a student the other day at a recruiting event, like she was interested in maybe going to Hershey Medical Center, and they do a lot of like, it's a big hospital. They have like a pediatric team there. And she's like, I really like peds. And I'm like, well, you could come and work with us for a year, get more specialized in pediatrics, and then go back to Hershey after a year and be part of their peds team. And I think we're going to see more and more of this. And I think it's going to help drive our profession forward with these specialties more and more.
Totally.
I'm really excited about that.
I'm excited about it too. How long has this process taken you from initiation? Because it sounds like you've really spearheaded a lot of this.
I worked on this 100% by myself. This was a solo gal project, and it took about 18 months. So I started working on it, and this is like, it's like my son was born. So it's like before Nate and after Nate. And I started working on it before he was born. And then let me think. So I had started reaching out to them. I had started putting stuff together, like talking to leadership in our department, making sure that we were all on the same page, that we were going to have the resources and the support to go ahead with this. And then I would say before he was born, 2 summers ago. So this was his first summer, 2024, 2023. So the summer of 2023, I really started putting like the bulk of this together. And then I submitted it in June of 2024, because that's when they have like their review in the summer where they go over all of this stuff. So they went over the things that I submitted. And then at the end of July, I had a meeting with the Council of Accreditation Review Committee. And it was a Zoom call type thing or Teams meeting, something like that. And I was on with like 6 other people. And it was intimidating because they look at everything you submitted and they find the holes, they find the things that they think are weak spots, and they ask you about it. And it's like, what are you going to do to ensure this? What are you going to do to make sure that this doesn't happen? How are you going to make sure that they get these numbers? What's your plan for this? What if someone got sick? Are you going to like grant them an extension for the time that they were out? Language is really important just to make sure that it's very ironclad in the way that you're explaining things. So I did that in July. It came back to me in September with their recommendations of things that they felt that I needed to update to make the application stronger. So then I had a chance to go in and revise them. In addition to this self-study that they gave you that was like 20 pages long, I had to come up with like a fellowship handbook, job descriptions for the program director, which is what I will be if it gets approved. I have like literally the whole alphabet worth of appendices of like different things explaining like, you know, this is the caveat here, this is the didactic curriculum, this is the evaluation form that physicians can use for the fellows, this is the evaluation form that the fellows can use for their mentors. Like there's so much involved. And then at the end of October, they sat for their big Council of Accreditation meeting. And I will find out on November 19th if we got approved or not. So I think with the amount of feedback that came back after the initial review, I feel really hopeful that it's going to get approved.
That's going to be, again, so exciting, not only for your hospital and such an accomplishment for you, but again, so good for the profession because like we said earlier, fellowships have not always existed in this way for physicians. And I think it's really improved the anesthesia care that high risk complex patients receive across the nation, across the globe. And I think it's really exciting that the CRNA world is starting to pioneer this as well. We all can benefit from more education, more specialization, especially as you know, our patient population gets sicker, more complex, or we want to work in these really nuanced areas. You just can't cover it all in your general education, no matter how you train. What is one piece of advice, Kate, for someone who is an aspiring CRNA, a new grad CRNA who wants to get into pediatrics, but doesn't know where to start? Like, what are the attributes that they should have as a provider? What are some things that they should look into? Like, what are you looking for when you accept a fellow, ideally, or a new hire?
Yeah, this is such a great question. And there's multitudes to the answer. So I'll try to keep it like as short and sweet as possible. I think if it's someone who's still in their ICU phase, if you know, like you're interested in pediatrics, try to get into a pediatric ICU. There's definitely big pediatric medical centers like Boston Children's, like CHOP, that are going to look favorably at someone who has a pediatric background if they're interested in going into pediatric anesthesia. The desire to be in pediatrics needs to come from a place of deeply caring for your patient, to being committed to a meticulous nature, and setting your ego aside. I know a lot of people who go like, babies are so cute, I want to do pediatrics. And I'm like, that's not enough. Like, yes, babies are so cute, but like you need to have the sharpest attention to detail when you're working in pediatrics. You have to have so much precision, and you really, really, really have to be able to set your ego aside. And that's a hard thing to do. It's a hard thing for anyone. But it's the kind of thing where like, if I know that I am not the most skilled airway provider in the room and we have a really challenging airway, I'm not going to be like, well, I want to try with the fiber optic on this tiny NICU baby. Not that everyone doesn't need to learn, but it's like, you got one shot at this. And like, that's not the time for the learning experience for me. I'll practice and get up to that point. And I think that's hard sometimes. Students come in and they're like how I was, where they're like, I got this. I'm really good at masking. I'm really good at airways. And I'm like, but these are different types of masking and different types of airways. And like, you just need to have a lot of humility and be open to learning. And I think like another part of pediatrics is just being like open to the magic of pediatrics. So like, I'm of course extremely proud and feel very satisfied at the end of the day if like I do a beautiful anesthetic and I have railroad track vital signs the whole time, and then the child wakes up beautifully and they don't throw up in the PACU and everyone's happy. But the thing that makes me the most proud is when I have a kid who's really anxious in pre-op and I see them starting to escalate and I'm able to bond and connect with them over something like they're watching Bluey. And I'm like, oh my God, I love Bluey. Like, did you ever see the episode where they play doctor? And like, and you know how they hold the mask over that? We're going to do that when we go in the room. And then like taking that kid from that moment of feeling so scared, and the parents are feeling scared too, and seeing them see their child connect with someone on their level and bring them back to the room and turn it into this fun experience. And then they're laughing through their mask induction instead of crying and fighting. Like, that's the thing that makes me feel the best at the end of the day. Or a teenage girl who's afraid to get her IV. And I'm like, why don't we listen to Taylor Swift? And they're like, oh my God, I love Taylor Swift. And I'm like, girl, me too. And then like we end up listening to our favorite Taylor Swift song to get our IV, and it's not a big deal. Like, those are the things at the end of the day that I truly feel the most satisfied and the most proud of. So I think if those are the things that are going to make the difference in how you feel at the end of the day at work, like pediatrics might be the right place for you.
Kate, I am already so grateful to not only have you as a friend and a colleague, but also as an educator in Confident Care Academy. Like, her lectures, guys, are so good. Like, I listen to Kate's lectures to review. Like, I love them. I could listen to her talk for days. Your patients are so lucky to have you.
Thank you.
I imagine if I was a parent, I would be so relieved if you started playing Taylor Swift and talking about friendship bracelets with my teenage daughter. Like, they're so lucky to have you. You are such a gift to this profession. And I really encourage you guys to just take inspiration from mentors like Kate, because everyone's going to have their own interest in anesthesia and motivations for this career and experience different work environments, different challenges. You're going to go down a million different pathways here, but taking away that spirit of really putting the patient in the center and putting your ego aside is the number one characteristic that you need to have as a CRNA, no matter what environment you work in. And it's such an amazing lesson to take home, and giving that, putting that patient first. I work primarily in adults. It's what resonates with people. It's what people remember on the scariest day of their life, the most vulnerable moment of their life, right? That you connected with them and you earned their trust in 15 minutes or less. That's really the beauty of it. So again, thank you so much for coming on and talking to us today, Kate. Guys, you're going to be seeing a lot more of Kate, which I'm really excited about on the podcast. If you're a Confident Care Academy member, we're going to be seeing a lot more of her. So thank you again for just being part of this community. We really appreciate you being here.
I will add that I listened to your pediatric airway lecture 3 times for my peds anesthesia exam.
Oh my God.
In anesthesia school. If you want that lecture, it's up in the Confident Care Academy membership and community. It's gold. I will be reviewing it again before boards. And we're so excited to have you now and ongoing in the future. You're just a wealth of knowledge.
Thank you. Chrissy and Anna, you guys are both such inspirations. And I feel so lucky to be part of a community that you two have created. And that even though we're not all exactly the same, I feel like our overall values and ideals all align. And I'm so lucky to get to be part of this with both of you. And I'm so inspired by both of you every day.
Well, we're excited for the future. Let's make it awesome.
Yes.
Guys, we'll see you in the next episode. Make sure you are subscribed so you get the notification when it hits. Drop your comments below if you have questions for Kate. Our next episode, we're going to have another special guest for you. We're going to be talking about some CRNA advocacy, CRNA politics. It is a hot topic. There's a lot of confusion and myth busting out there. So if you're interested in becoming a CRNA or learning a little bit more, make sure you tune in. We'll see you there.